He's a senior eye specialist from Civil Hospital, as well as she's a treasurer of Indian Medical Association, Mizoram branch. I welcome her, and please come up and give your interesting topic, medico-legal ethics. Okay.
Thank you, Dr. Remsanga and Dr. K.K. Chetri, our respected legal ethics. This is for, we will be talking about the medical ethics which should be followed by each medical practitioner. So what is ethics? Ethics signifies moral values. And medical ethics is a moral principles for registered medical practitioners in their dealings with each other, in their dealings with their patients and the state. Next evening like that. Okay. So what is medical etiquette? It is a conventional laws, customs of courtesy and code of conduct for doctor with his colleagues. We should have a medical etiquette with our medical colleagues, professional colleagues. The Indian Medical Council, it is formed for the recognition of any medical qualification and to supervise undergraduate medical education and postgraduate medical education, and for recognition of foreign medical education, and for any de-recognition. Then for medical registration, then it can issue warning notice, then it can appeal against disciplinary action. Even in Mizoram, we have Mizoram State Medical Council. So the State Medical Council, what they have to do is, they have to register those medical doctors, and it can have a disciplinary control for the medical doctors who are registered under them. Then it can issue a warning notice, then it can give a professional death sentence. That means it can cancel their professional license to practice medical. Duties of a medical practitioners towards patients. It's treatment of patient, which is implied contract. Then duty to the sick and duty to continue treatment. Then to earn confidence and duty to children and infirm, charge for professional service, then the right to choose a patient, then duty to give proper directions, duty to offer proper regime of treatment, then to notify communicable diseases. Village communication. This is a bona fide statement of a registered medical person on a subject matter of public interest to the concerned authority to protect the interests of the community. This privileged communication, like supposing a patient is having sexually transmitted diseases like gonorrhea and all, if the patient is not willing to follow what the doctor had advised, then this doctor can inform the State Medical Council, and they can have a privileged communication to the community. Then the medical practitioners, we have duties towards the state, that is for notification of any infectious diseases, then notice to the police for any medico-legal cases. Then notification of births and deaths, then we issuing of certificates, and then respond to emergency military services. Then we have a duty towards one another. Each medical practitioners, we have to follow a duty towards one another. That is, we have to extend same honor, respect, and good behavior as expected from them. Then we should not do or utter anything to lower down the name of a colleague. This is a very, very important rules and duties. Then we should not entice patients away from colleagues. We should not entice patients away from our colleagues. Then free medical service to fellow colleagues. This we follow it very well. amongst our members in Mizoram. I hope you all follow this. Even to our colleagues, family members, we follow this one, I think so. And I hope we continue that. Then professional misconduct. This is a conduct considered as disgraceful or dishonorable by professional burden of good repute and competency. These are, if we issue a false medical certificates, covering up unqualified persons, then if we help a quack, then canvassing, then this issue of false medical certificate, it's a very, very serious matter. To personally open chemist shop, then to describe habit-forming drugs, then disclosing professional secrets of patients. And if we fail to notify any communicable diseases or any medico-legal cases to the police or to the concerned persons, then treating patients under the influence of drink or drugs. We cannot treat our patients if we are under the influence of a drink or a drug. Then fee splitting or dichotomy. This is, I hope it's not practiced in Mizoram, but it's, I think in other parts of India it's practiced. Like fee splitting means if we have a collaboration or something to do with like laboratories and all. This is not good, encourage. Then professional negligence. This is called malpraxis. Negligence is doing something that one is not supposed to do or failing to do something that he is supposed to do. Then professional negligence is absence of reasonable care and skill or willful negligence of a medical practitioner in the treatment of patient which causes bodily injury or death of a patient. Civil negligence. Following conditions should be satisfied for proving liability of negligence. That is the existence of a duty of care by the doctor. Then dereliction, failure on the part of doctor to maintain applicable standard of care and skill. Then direct causation, any damage was caused by breach of duty. Then number 4 is damage, that is lost wages, medical expenses, and mental duress. Contributory negligence, it is a concurrent negligent act or unreasonable conduct on the part of the patient, then not a defense in case of criminal negligence. The misadventure is dangerous, unforeseeable effects following use of some procedure, measures, or drugs. Then therapeutic, diagnostic, and experimental. Vicarious liability is the liability of an employer for the negligent act of his employees within the course and scope of their employment. It is the principle of respondent superior. Criminal malpractice. Medical practitioner prosecuted in criminal court on the charge of having caused death of his patient. Then by a rash or negligent act not amounting to murder. Then gross carelessness in the treatment. Then section 304A IPC. That is criminal malpractice. Then consent. This is an agreement, compliance or permission given voluntarily without compulsion. Then there are 2 types of consent, that is express and implied. In express, they are verbal and written. Informed consent, nature of ailment or disease process. Nature and plan of proposed line of treatment. Then we have to informed about the alternative form or line of treatment. Then nature of risk involved in both. Then relative chances of success, benefit, and burden or failure. Then we have to give them the freedom of choice. We can tell them to choose between the treatments. Then express consent always before any procedure beyond ordinary medical examination. Then open consent. A child below 12 years cannot give valid consent, so we have to take from the parents or the guardians. Then consent given under fear, misinterpretation by insane or intoxicated person is not valid. That is under section 190 IPC. Then it is not an offense when any harm is caused by any act done in good faith, even without consent, under circumstances when it was not possible to take the consent under section 92 IPC.
Here our chief moderator has come from ZMC. Welcome you. We are just started the topic medical legal cases. So whether it is interesting or not, we are bound to follow this principle. Otherwise, there are many malpractices among the community of doctors. Not only, there are also what we call quacks, those who try to be doctors, who are trying to be treat the patient without medical ethics. So, shall I call the chief moderator to come forward, and if he would like to say anything, I request to speak whatever he likes.
The first presentation as we all know, Madam has presented nicely. Dr. Lal Hutang is one of the most senior ophthalmologists in our state. She has done a lot for our community. And as she rightly pointed out, what are the ethical values we have to imbibe among ourselves, towards the patients, towards the community, and towards our colleagues. So she has pointed out all the medical ethics which we all have to follow. Today we are celebrating this 23rd anniversary of this eye care center under Dr. Purem Sangha. There are, at this CMB we have three speakers, three eminent speakers. We have one we have just concluded from our state, Dr. Lal Hutangi, and two more are from Kolkata. We are waiting. So for the time being, we can ask any questions or any discussion from the audience or from anyone who we can discuss or point out whatever ethical issues or whatever problem we face in our practice. Topic. So kindly come here, Dr. Lara.
Thank you, sir. This is not in the program at all, and I'm just using the time to fill up. I'm just using this to fill up the time till we wait for our real speakers. Since Dr. Maiti will be talking about Razumab, and since some of us are non-medical, I thought maybe I would introduce you to the drug. A lot of us might not even know what an anti-VEGF is. So anti-VEGF, the full form is anti-vascular endothelial growth factor. So for a long term, for a long time, for retinal diseases, we only have two modalities. It's either laser or steroids or vitrectomy surgery. So medical retina was very limited. We did not have any drug that we could turn to for the edemas and for the neovascularization. So it's either laser, which is really, really damaging to the retina, because whenever we burn the retina, there is a risk of visual field loss. There is a risk of having scotomas and black spots. So when the anti-VEGF came around for the first time, which is more than 10 years now, it was a welcome change. It started off with a drug called bevacizumab, which is actually not meant for the eye. It is a cancer therapy. It was meant for rectal cancers. And it was a full-length antibody, and it binds to all isoforms of VEGF, not just VEGF-A. It binds to all the A, B, C, Ds, I don't know what all the names was. It binds to all the isoforms. And the thing is that the retina VEGF is quite specific. For the retina, the VEGF is VEGF-A. And if we have an anti-VEGF which binds to all the isoforms of VEGF, it's a bit dangerous because they can have serious problems. They can have heart problems. They can have heart complications, stroke, and so on. So it was not done. Anyway, the brand name was Avastin. It came in a vial, and we used to distribute this vial to around 10 patients, and it was not very sanitary. It was not very sterile like that, because we had to distribute it among like 10 patients, and supposing one vial was infected, now all the 12 patients will get infected. They would get endophthalmitis, uveitis, and so on. So it was not apt for the eye. And as you know, the eye has to be super sterile. Of all the OTs that we have, IOT has to be kept the most sterile, right? Next, the companies came up with a very good drug, ranibizumab, which is again the full-length antibody, but now it is specific to VEGF-A, which is the VEGF of the eye. Now, what is this vascular endothelial growth factor? Vascular endothelial growth factor is a notorious, you can say, molecule, biomolecule, which is the main culprit in neovascularization. And it is stimulated by hypoxia, not anoxia. Hypoxia meaning the lack of oxygen. So when you have less oxygen in the retina, it follows a pathway and it leads to stimulation of hypoxia-inducible factor beta and so on, and eventually we have release of VEGF. And when VEGF gets released, you get new formation of small blood vessels which are leaky and very, very dangerous for the eye because they start bleeding like anything. And that causes vitreous hemorrhage, that causes retinal hemorrhages, neovascular membranes, and so on. So it is the target molecule for all this anti-VEGF. So after ranibizumab came along, it was quite good, it was quite safe, but the problem was that it was quite costly. Later on, we have other molecules like pegaptinib, aflibercept, Macugen, so on, but most of these are quite costly, so companies are looking forward to drugs which are having similar efficacies, but at a lower cost. So now we have the first biosimilar of ranibizumab, I believe is Razumab, which is from Intas Pharmaceuticals. It's Indian-born, so it's quite special that way. And Dr. Maiti will be coming and talking about his experience with ranibizumab. I believe Lucentis and Eccentrix, which are the brand name for ranibizumab, they come at around 35,000, 40,000 per injection. And Razumab would be something around 25,000 20,000 to 25,000. So it's quite cheaper that way also. If it were to produce the same result, it would be lovely. So we'll be hearing about that. One of the newest anti-VEGF again would be brolucizumab, which comes under the name Peginex, which is quite good because it has been found to have a decrease in the number of injections, because as we know, anti-VEGFs, we need to inject them every 1 month or so. So there is a decrease in the cost with brolucizumab, and it has a side effect of increasing inflammation, uveitis. So except for that, brolucizumab is another drug we have to look out for. Not really a presentation, just a small speech here. Does anybody have any question? We use these anti-VEGFs for diabetic macular edema. We use it for ARMD, for neovascularization. We also use it for vitreous hemorrhages. Yeah, why? You are the right person to come and talk about it. Okay, I will hand over the controls to our moderator again.
How the effect lasts. I don't know with this rozumab, but that Avastin, there were some complaints of this, since it was acting on the blood vessels, there were reports of all this optic atrophy, all these side effects were reported. But nonetheless, many patients around the world has benefited from this anti-VEGF. The dexamethasone implant. This one, this is a very effective drug, especially in uveitis. You implant it there. It is slowly releasing drug. It releases slowly the steroids in the vitreous cavity, so it is very effective. And from anyone from Alcon? Please.
Dr. Ramsingha, and my regards to all present out here. I really fallen in love with Aizawl, fantastic place, and really an opportunity to speak few words about Alcon. Now, we being a part of this ophthalmic fraternity, our journey started in Texas 1947, where at that point of time, eye care was not very organized. And as somebody says, infection, those were a regular part of occurrences. So two people planned that we should be doing something dedicatedly for eye, and which is actually a window to the rest of the world. So for India part of Alcon is concerned, it started coming from the 1990s, and with very preliminary product, but in India also, scenario remained very same, but it was underprivileged. Not a very organized, lot of patients are there, doctors were not given very good quality resources to serve the community. So I feel very proud that Alcon being one of such companies who have taken the baton, not only with the doctors to serve better, also with the government to have better arrangement for the doctors, hospitals, so that better facilities could have been rendered to poor patients. Now I feel very nice to see that the very first topic of today's session was medical ethics. Medical ethics and patient care is the baseline in Alcon globally. Anything and everything starts with ethical practice, and it should end with the best and the superb quality of patient care. Finance, supply, these are the part, but that all comes later. So I was feeling very nice that this topic was discussed. In very occasions we see that ethical practice is discussed. So thank you, sir, for having such a particular topic there. Now what we do in Alcon, especially in India, In India, we found that there are a lot of work has to be done. My association with Alcon surgical part is around 17 years. So when we really started working very hard in India, especially in eastern part of India, infrastructure, those are not there. So we initially started having the market to be developed with whatever best possible resources can be given to the doctors. There were incidences of endophthalmitis being very high. Initially, when doctors started practicing, the concept of infection prevention was also not very high. So Alcon being one of the companies, not only to provide resources to the doctors, also to provide the procedures and protocols, so that after a very hard work day, the results in a doctor's hand should be very smiling. You do a very good surgery, but after the surgery, the results are not very encouraging. So it gives a demoralizing effect to the doctors. So it was the intraocular lenses, the machines which does the best of the class surgery to the doctor, the patients. At the same time, we found that there are infrastructure which are very lacking, where new generation doctors can start learning better ophthalmology. It is not only the academics, the practical part of it. Once you are into colleges and doctors and under the guidance of best of the hands, you feel very secured. But once you come back to your own place, in your own setup, the confidence is somewhere not that very strong. So Alcon started with a kind of totally different vertical, fully organized to stand beside the doctors, analyze what support is really going to make a real difference, a motivation for them, development for them, provide them and ensure they are really getting that from Alcon. So in a very brief, I will not stretch my statement much better. Alcon is a company which actually aligns with the requirement of the doctors in eye practices. And we always try to learn from the doctors. Though we always want to know what can get a better to the doctors, but constantly it's a learning process for us. That's what we visit doctors' chambers, operation theaters, so that it's always a mutual learning process in the both ways. Thank you very much. And today's session also is going to be very interesting, and we feel we go more enriched today by learning from you all. Thank you.
A small speech from Intas, who developed this new wonder drug, Razumab. Please come here.
Everybody, and thanks, sir, for giving us an opportunity to present on behalf of Intas what we have come out with. We launched these biologics in 2015, Ranibizumab, which was globally the first company who has developed a biosimilar. Initially, we got some challenges because the product, its a pharmacopoeia, was not available anywhere. So our R&D team has developed since 2007, when Genentech has developed the molecule and got the approval worldwide. We started developing from that time. And finally, we came out in 2012, we cracked the molecule in India. And then it became a globally number one, first company come up with a biosimilar. Then followed up with last 6 years, around 2.5 lakh procedures has been done successfully. Whatever the challenges we faced earlier, all those things have been overcome by R&D, and now almost in all the government sector, now Razumab has been in a rate contract. In CGHS it is there, in ESIC it is there, in Army, DGFMS, in ECHS, every segment it is there. Even in the Northern Railway, Eastern Railway, Southeastern Railway, where Razumab is going successfully. Yes, now apart from the government segment, there are the private institute also, big institute also, those who has initiated the trial, and they have published articles also in national, international journals. In the last 6 years, so we have now a total 17 national and international publications on safety efficacy part, on even it is FDA means in Indian FDA approved, it is DCGI CDSCO approved. In 2015 2012 we got the approval, and then in 2015 we launched the product after all the clinical trials, and we got the approval for all the 4 indications in the 2015. And we got another two approval for the PDR and for ROP in last month only. After giving all the PSUR safety data, we have received. So now this is the only biosimilar globally which is approved in all the 6 indications like the innovator brand. So this is the plus point. Plus, apart from this stability, it has already proven 36-month shelf life it is there. So this is all about developed by Intas, and it is manufactured in our only bio plant in Ahmedabad. So it is made in India, and Ahmedabad we are already, Intas is having 18 biosimilar products. Apart from ophthalmology, they have in oncology, rheumatology also. So this is how the Intas company is. So we are working in developing the molecules, and even in the future molecules are also ready with us, just waiting for the patent to get expired. So once the patent will expire, definitely we will come up with aflibercept and aflibercept also. So these are there in a pipeline. Another pipeline is what we are coming up with Razumab in pre-filled also. So hopefully by another 6 months we will launch that PFS also. Thank you, sir. Thank you.
Was it really significant?
It's not the better right person is a person who did the trial, and Dr. Anirudh Maiti has done the trial. So that's the reason why because this asset study is a phase 4 study, and where a multicentric study was there. One of the centers was at that time where Dr. Anirudh Maiti was there. So he led. So he is the right person to answer these things. Although it is not that significant in that way, but he is the right person who can go through all the things about this beneficial effect, as well as what if even any ideas are there, he is the right person to address on this. Thank you. Thanks.
Now we invite Dr. Remsanga to kindly come here and give out the certificate.
Hello. Ngoro, I'm point there. Kitchen. Oh, Ngoro.
Okay. This participation certificate is signed by the Register, Mizoram State Medical Council, and the organizing chairman. First is Dr. K.K. Chetri. And the next is to
Professor Dr. Zoram Thanga. He's our chief moderator. Okay. Yes. Okay.
now we'll invite Dr. K.K. Chetri to distribute the rest of the certificate. Sir, please come here. Dr. C.H. Sarakam Aimol.
Betul lah, doon maksudnya. Yes, sir.
Firdaus Jaman. Dr. Lalbi Akluangi. Katia Kayana. Lal Huzwali. CMB. Our two speakers, eminent ophthalmologists from Kolkata, has just arrived. Now we shall call upon Dr. Siddhartha Ghosh. He is a very eminent ophthalmologist. He has done a lot of surgery and he has presented in many national and international conferences. He specializes in cataract and refractive surgery. Also, he does retinal laser treatment and medical retina. So, everyone welcome Dr. Siddhartha Ghosh.
Sorry, we are late a little bit because the flight couldn't arrive on time. The weather was a little, difficult today. Well, let me begin with my talk. It's adopting refractive cataract practice. I understand all of you are into this practice, but this is just to discuss the salient things that we practice in our day-to-day life and what we need to actually look into. This is just to tell you the overview that the functions of the lens, including what it does is it refracts light to focus a clear image on the retina and provides accommodation. Now, a cataract is an opacification of the crystalline lens, we all know, that leads to visual impairment. And there are many risk factors. The commonest is, we know that the commonest cause of cataract is aging, but there are many other causes and there are many risk factors as well. But the avoidable risk factor for cataract is use of tobacco products and exposure to ultraviolet radiation. These are two major risk factors. And coming to the treatment of cataract, when cataract becomes visually significant, cataract surgery is the only established method for treatment of cataract that we all know. Now, the only point is, what is visually significant? What does it mean? Currently, the definition of visually significant cataract has been changing over time. At this point of time, the most accepted cutoff is 20/40 or worse vision is thought to be visually significant for cataract surgery. Well, we have all seen and gone through the evolution of cataract surgery, and cataract surgery, as we know, is one of the most common procedures performed worldwide. And it is one of the oldest as well, one of the oldest surgeries in the world. And cataract may be considered among the most successful treatments in all of medicine, in all of medical science, So it's interesting to note that this is one of the oldest surgeries in medical science, where, dates back to 6th century BC, 600 BC. And interestingly, one of the pioneers was from India. So, but then it has come a very long way. And interestingly, it is one of the most successful of the surgeries worldwide. Now, we know that we have gone across ECC, ICC, and all those stages come to phacoemulsification. It has evolved to a great extent. But cataract surgery has moved now from merely a vision restoration to vision enhancement over the past few years. And therefore, there is a need of superior performance at every stage of the surgery, which is really of paramount importance. And we need to understand our patients. We need to understand what they need. And that is the key to adoption of, cataract refractive practice. Now, we need to understand what's best for our patients. And for that, we need to believe in technology. We need to understand the technology. And to understand the importance of patients' conversation, like we need to take time off to understand and discuss the available technologies with our patients. That is the key to adopting refractive cataract practice. And by that, what I mean is, you need to match the technology to the patient. that is having the patients rate their visual disability and determine the needs for distance, intermediate and near vision for that particular patient. And what is most important for the patient needs to be identified. Sometimes we use a lifestyle questionnaire to establish the patient's need, visual need. And then we try to match the current technology available, which is most suitable for the patient. And we need to establish a very reasonable expectation for the patient. We may talk of very big heroic surgeries, but we need to understand what the patient needs and what he should expect. What the patient should expect is also, it should be reasonable, because it is not just that we can give a perfect outcome to every patient. So we need to customize. We need to make it very simple for all our patients. We need to make it simple. By that, we mean that if we keep discussing technology, patients might get confused. So let us not confuse our patients. Let us understand what their needs are. And the best way is to take the onus on us, and we make a recommendation of one implant that seems to fit the patient's needs and the desires best in the best way. So that is again very important. Let us understand that one size doesn't fit all. So there comes the customization, need for customization for every patient. We need to understand the need, and of course we need to counsel these patients according to their need, and let us not give them something which is beyond reach. So we need to understand their needs, and we need to counsel them for what they expect. And let us tell them that not all patients, like 90% of patients would pass the driver's test, the driving license test. But some of them may need a pair of glasses to read or look at the signs at night. So some patients may need glasses for other tasks. So let us not think that we are giving a new technology, a big technology. That doesn't mean that everything is going to be perfect for him or her. Well, we should be very clear and unapologetic about the higher costs of technology, because we need to understand that newer technologies are costly, but they give immense benefit. So we should be very clear with our patients about that. And of course, we always think of pre-operative counseling, but post-operative counseling is equally important, because we need to talk to our patients and understand how much they have achieved, how much they have got, and accordingly, we can mix and match for the other eye. So the foundation of refractive vision is actually not just one spherical correction. It's spherical as well as cylinder corrections, and the most the patient needs to be corrected. The maximal correction that is possible needs to be given. And the treatment of astigmatism and presbyopia actually is the foundation where cataract surgery becomes cataract refractive surgery. So treating astigmatism and presbyopia is very important to practice cataract refractive surgery. For that, we need advanced support equipments, and these are the ones which we really need. We need to plan with a very great refractive precision, for each eye is unique. So we need to we need this image-guided surgical planning and navigation system for each of our patients to customize and be precise for the needs of the patient. Now, image-guided cataract surgery is like the GPS of cataract surgery. Here, in the diagnostics, we measure, and then in the workflow, we take the other details, preoperative measurements like keratometry, limbus, pupil, vessel detection, and all these are done preoperatively. Then we plan in the planner module. We need to make sure that we use the right formula for IOL power calculations. For example, the latest is the Barrett suite, which gives the most accurate results as of now. because it consists of many, many algorithms for even post-LASIK cases, post-refractive surgery cases. And because it takes into account lot of values, lot of data which can be calculated, and this is the most accurate as of now, for surgical planning, like the incision, implantation axis, the centration of IOL, all this can be done. And these data, when it is transmitted to our microscope in the OT, it can really be very useful, because I'll just show you in a moment how we can precisely make incisions, align the toric IOLs, and of course, we can make sure that the rhexis is in the center, pupillary center, or maybe visual axis center, and then we can precisely align the toric IOLs. This is just one of my surgeries. This was a live surgery show. So here you can see that this is the point. The marker is showing this is the point of incision. So you can precisely mark the incision. You can see on the microscope where to make the incision, how big should be the rhexis. It's also showing continuously. As the eye moves, it tracks the eye, and the centration remains the same. Now, since this marking is there, we can just follow doing rhexis along the marks, and we can be dot precise so that the rhexis is on the center of the visual axis. Now, all these are important because, here we need to precisely center the IOL, because the concept of effective lens position comes. We'll discuss that tomorrow in another talk, maybe. Now, as you can see, the eye is moving, but you can still follow. The tracker keeps on moving, and you can precisely make the rhexis. Now, sorry. I'll just... Okay. Now, this is another one where you can see that this is a marker. This is a digital marker, and you can align the toric lens according to the dots, 3 dots. Well, progress of technology doesn't stop here. This is just another technology. It's femtosecond laser cataract surgery, where you can again precisely make a rhexis. The rhexis has already made by the laser, and you can just peel it off. Simple. And the pre-chops have been made with lasers, so you can just take separate the pieces very easily, because they have already been done with femtosecond laser. And very less energy is required, because the major cracking and chopping has already been done. So these are really interesting developments, and these are essential. Technological advancement is really essential for adopting refractive cataract practice. Well, even after when this is done, when you implant the lens, you can see how well it is centered, and even the incisions are also very precise. So cataract surgery has evolved into a refractive procedure rather than a simple surgical treatment of cataract. So there has been lot of developments, lot of IOL materials, lot of IOLs have come into being, lot of new technologies to make surgeries precise. But the perfection is still elusive. The bar shifts higher and higher every time. There remains room for improvement, but the future of cataract surgery will be incredible as advances continue to evolve. Together, let us help this technology reach our patients who can benefit from them. Thank you.
So any question from the audience? No, sir. Sir is a very good surgeon. I've seen your video that AIOC, you have presented that the post-traumatic cataract with iridodialysis, that repair, that was wonderful. And I welcome Dr. Anuradha also. So if there is no question, we shall move on to the next presentation. Sir, I think he doesn't need any introduction. He has done a lot, and he has published a lot regarding this new multicentric trial set you have published also. I have read it, very interesting. So sir is a member of not only AIOS. He's a member of many international society. He has presented in a lot of conferences also. So welcome, sir, and thank you a lot for coming here.
Extremely sorry for the delay. I think the weather was not that great. It took a long time. Well, at the outset, I would like to thank Dr. M. Sangha and the entire team for this kind invitation. Well, today I will be sharing my experience with a new molecule, my experience in a real world scenario with a Razumab. Well, what is it? The Razumab is the first biosimilar molecule in ophthalmology. We will come to it, what is a biosimilar molecule, what is it like, and this was first approved in India in 2015. It is by the Intas company. And let's come to the basic, what is a biosimilar molecule? Well, a biological product is highly similar to the reference product, notwithstanding minor differences in the clinically inactive components. So, grossly we can say it's product pretty much similar to a parent molecule which we have been using for many years. It can be not similar, similar, highly similar, or highly similar with a fingerprint-like similarity. So we are looking for something like a fingerprint-like similarity. Now, this is a very rigorous process. There is a clinical part, non-clinical part, analytical similarity, and the similarity should be as far as the identity, the analytical structure is concerned, physiochemical properties, biological, and functional. And in a whole, this process of biosimilar medicine development involves a rigorous analytical study to establish comprehensive understanding of the similarity of the biosimilar to the reference product. Ultimately, the goal is to demonstrate that there is no clinical meaningful difference between the reference product and the biosimilar based on the finding from all of the studies. Now, we are not going into the details of the structures. Multiple parameters need to be analytically similarity. Now, what is it? This is a biosimilar to ranibizumab. We are frequently we are used to this molecule as an anti-VEGF molecule which we are using for the last 15 years in various retinal conditions. It's an FAV fragment targeted against the human VEGF-A. Now, the preclinical studies was conducted in 2012. The phase 3 trials started in October 2013. I was lucky enough to be associated with this trial as well. And the DCGI gave approval to this biosimilar molecule in February 2015. We are not going into the details of the structural details of the molecule, but we should be aware that this molecule is similar to the structure of the parent molecule, whether it's a primary structure, secondary, or a tertiary structure. And as far as the purity goes, it should be similar and matched to the parent product, which it proved to be. Now, there was always an unmet need in the retinal diseases, treatment of retinal diseases in India. Around 1.1 crore people suffer from the retinal diseases in India. If you consider only diabetes, there will be around 134 million population by 2045. And India happens to be the diabetes capital of the world. Now, every third person with a type 2 diabetes has diabetic retinopathy, and every fifth person with the type 2 diabetes has a sight-threatening diabetic retinopathy. Now, if we consider the entire population of 125 crores, the diabetic population is greater than 7 crores. And out of this 7 crores, 7%, that is 49 lakhs, has a diabetic macular edema. So, 50 lakh of population is having a sight-threatening caused due to diabetic macular edema, and on the other hand, the retinal venous occlusion, which is also another 54 lakhs. So total around 1 crore, greater than 1 crore patients need a treatment which is called an anti-VEGF. Now, the existing anti-VEGFs are mostly they are from foreign countries, and obviously due to the R&D part and the importing cost, the tax part, they are pretty expensive. So around half of the population with a DME or an age-related macular degeneration or RVO are lost to follow-up to intravitreal anti-VEGF. They cannot afford the treatment. So the most common problem is non-affordability. Now, the biosimilars, now what are the challenges to this anti-VEGF treatment? We all know that 18 to 22% of the Indian population is below the poverty line. And the India per capita income is mere $720 compared to $43,740 of US. So treatment costs are not covered by most of the insurance companies or the sponsored by government agencies, and so most of the dropout of treatment occurs because it proves to be very expensive. Obviously, we do have some healthcare, but those are not enough. So the biosimilar is going to address this major problem. The cost-effective option to improve the patient's access, the biosimilar is actually reduces the treatment cost by 25 to 50% when compared to the parent biological drugs. So this is why the biosimilars are so popular and we use very frequently, because the main reason for the non-clamp plans is affordability. And interestingly, the study carried out in the United States over 10 years, the biosimilar use can save $54 billion US in the United States. That's a lot of money. So the cost comparison of intravitreal anti-VEGF treatment in India, the Razumab, the biosimilar molecule, is relatively inexpensive. If we convert into US dollar, it's just $125, where Lucentis, which is the common brand we have been using for the last 15 years, it is $320. Eylea is even more expensive, $760, and the newest molecule, that is the Bevu, or in India it's called the Peganax, is $350. So if we come to the other biosimilar molecules, there's the entire list of the biosimilar molecules which is used in various cancers. Razumab is the only one which was approved in ophthalmology. Now, coming to the clinical evidences, obviously, we need to be sure about the effectivity of this new medicines. We need to be sure about the safety profile of this new medicine. So, a lot of trials has been done to prove its effectiveness and the safety profile. So, this was a prospective clinical trial performed by Intas. There was a phase 3 trial where 104 patients were recruited, and phase 4 trial, 126 patients were recruited. All were wet AMD. And these two studies I was also associated. And we are not going into the details. We will come to the results of this trial. Regarding the efficacy part, the result of the study indicated that the proportion of the patient who lose less than 15 letters from the baseline visual acuity is 98.7% in the treatment of the ranibizumab, that is Razumab, Intas ranibizumab, as compared to 100% in the treatment arm of the comparative molecule. So it was pretty much similar. One was 98.7% and another was 100%. So it was quite efficacious, and as well as the safety and immunogenicity is concerned, it was pretty much similar to compared with the other anti-VEGF molecules. Now, this is an asset study which got published in 2021. We were a part of this study. This was done as a post-marketing trial, as a 6 months trial. This was also done to see the efficacy and the safety profile. And coming to the results, the mean increase in BCVA score by 9.2 letters at the end of the study from baseline, and the mean decrease in the central retinal thickness by 119.3 microns at the end of the study from the baseline. So the edema reduced and at the same time the vision also improved. There are other studies which also proves the effectiveness, not only the ASCET trial and the prospective trial which we were mentioning before was only, the indication was only neovascular AMD. The reenact studies was done for patients with wet AMD, DME, RVO and myopic CNVM. And it was the first one, the reenact was 12-week study, and the reenact 2 was a 48-week study. All the indications where the biosimilar was used. So it actually showed that is a improved visual acuity and the disease outcomes with no new safety concerns. So there was no serious adverse effect with the new biosimilar molecules, both in 3 months as well as the ENACT 2, which was the 48 weeks. There is similar study, which was CSER study. I'm not going into the details of this further studies, but all of them, this was interesting where they had compared, this was an comparison between the new molecule, the biosimilar molecule, with the other known molecules, that is the innovator, ranibizumab and bevacizumab, which are actually used frequently in a real world situation. And when these two molecules were compared, it showed that a change in visual acuity and the central foveal thickness at each monthly visit in neovascular AMD group for the biosimilar and the routinely used products. That is, one is a Lucentis and another is a Avastin. And it concluded that the biosimilar ranibizumab is comparable to the innovator ranibizumab and bevacizumab in efficacy and safety, which was our concern. Now, there is a big study performed by Disha. There's a large number of patients been recruited. More than 9,000 patients were recruited. And the key highlights from the Disha study showed that it was the largest pool safety data on this new molecule in real world scenario. And the study result did not raise any new ocular or the safety concerns of this molecule. The incidence and the spectrum of adverse effect were similar to those reported with any other anti-VEGF molecule. The real world evidence suggests that this new molecule, ranibizumab, is a safe anti-VEGF in the management of various chorioretinal diseases, as we mentioned before. And it was a large cohort of 9,406 injections treated with ranibizumab suggested that this is a safe alternative to approved anti-VEGF drugs. This was a similar study done in DME as well, and it also gave a similar result that has an acceptable ocular and systemic safety profile in patients with diabetic macular edema. There was a survey conducted by VRSS, the Vitreoretinal Society of India, which the key highlights were the VRSS survey revealed that the Indian vitreoretinal specialists are familiar with the anti-VEGF biosimilars. There was a progressive trend favoring this biosimilar molecules over Avastin, that is bevacizumab. 1/3 of the participants deemed the current price of ranibizumab biosimilar as appropriate to replace the Avastin. Simultaneously, the need for enhanced pharmacovigilance and larger clinical trials are warranted for regulatory approval of these drugs. So, in a nutshell, the DCGI approved for, this is the only molecule actually, DCGI is approved for not only in wet AMD, but also for the DME, RVO, myopic CNVM, PDR, and I think the latest is in ROP as well. Whereas the other biosimilars, which are pretty recent into the market, is approved only for the wet AMD. And it has conducted phase 3 and phase 4. This is the only one. The others are in the phase 3 level. And there is in total more than 17 publications on this new molecule. And the shelf life period of this molecule is 36 months. So this is in snapshot. DCGI approved for various indications. Till date, there is 250,000 injections been performed. More than 17 publications and more than 1,400 retinologists are using it. So this was all about the literature, the studies, And now few examples. This is a myopic CNVM with the injections of ranibizumab. You can see it responded pretty well, not only anatomically but also functionally. From 624 to 612, the vision improved. Similarly, this is another case where the lesion has almost disappeared with 3 injections of razumab. This is another CNVM. You can see the fluid has reduced, the lesion has subsided. The vision also stabilized from 624 to 618 without further decrease in vision, which is very important in CNVM. This is a PED which resolved pretty well with the injection of razumab, not only anatomically but also functionally. This is a pachychoroid disease responding pretty well with this new biosimilar molecule. So to conclude, this biosimilar molecule is quite safe, and it has been almost 6 years into the market, so it's a long time. Didn't found to work, it has been found to work other condition other than neovascular AMD like in DME and RVO as well as in ROP.